My lady, good afternoon. Can you hear me?
I can and see you. Thank you, Ms Carey.
May I call, please, Miss Michelle Dyson?
Just repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Have a seat.
Ms Dyson, thank you for coming along to help us.
Thank you.
Ms Dyson, your full name, please.
Michelle Sarah Dyson.
Would you mind just sitting a tiny bit more forward for the microphones to pick up your voice? And just take a moment to arrange yourself. There's no difficulty.
Okay.
Right. You, on behalf of the Department of Health and Social Care, have made 5 statements today. I won't read out the INQ references for all of them. And I think for your benefit and those that are following, the main one we'll be asking questions about is Part C, but all 5 will be published. Just a little bit about you, please, before we start with some of the topics. You are now the Director General for Adult Social Care, taking up that role initially on an interim basis, is that right, on the 17th of September 2020?
Yes.
And you were permanently appointed in May 2021.
Yes.
Can I ask, were you in DHSC, the department, at the start of 2020? Or did
No,
you join from somewhere else?
I was in the Department for Education.
All right. I think you are aware that certainly one of the witnesses to the inquiry has described that when he arrived in the Department of Health at the end of April, there being complete chaos. Obviously, you can't speak to April, but by the time you took up post in September, was there a sort of sense of chaos still pervasive at that time?
Before I get into that, could I just say a sort of overarching point?
Of course.
Since this is my first time in front of the inquiry. Yes. So I would like to say to everyone how sorry I am about all the terrible things that happened during the pandemic related to adult social care. I remember a conversation I had with a group of unpaid carers in 2020, hearing about their devastating experiences. I remember about a friend of mine telling me about his nephew who had learning disabilities, who died in a care home without seeing his family. And I remember being sent a booklet, I think by Rights for Residents, of stories of the terrible impact of lack of visiting. And then there are the care workers who went out to work when everyone else was locked down at home and in some cases lost their lives because of this. A really terrible time.
Ms Dyson, thank you. And we are going to pick up on some of those tragedies and some of that sadness as we go through. But thank you for your comments. Can I just jump back then to you joining the department in September? And do you think from your perspective it was still rather chaotic in the department at that time?
I mean, shall I comment about April? Because I have talked to others about what their experience was then. I mean, it was the case that the department had to massively scale up, including and maybe in particular in adult social care. So there were a lot of people joining from volunteers coming in from other departments to help. It was also the case that people had to change jobs overnight. I mean, it was the same in the Department for Education where I was at that time. We had to create new functions on PPE, on testing, etc. So there was a lot of movement. And so we didn't have time to do things that you would normally do, like organograms and induction, etc. We had to set up new decision-making structures. So it was a very, very fast-moving environment where people were working all hours. But from what I've heard, I wouldn't describe it as chaotic, rather very fast-moving. And it wasn't so dissimilar in September, although I'm sure it was slightly calmer by then.
Thank you. Well, it brings me on to one of the things I was going to ask you about, because as I understand it, the Director General of Adult Social Care was a new post, it having previously, I think, been joined with Director General for Adult Social Care and Primary Care, and then they split the two Director Generals. Do you know why there hadn't been a specific Adult Social Care Director General post prior to its inception?
I suppose it was felt that there hadn't been a particular need to have a separate post. I mean, it's important to remember there was still, there was a director of adult social care. There was still focus on it. But during the course of the pandemic, particularly in those early months, it became clear that, you needed a bigger function for adult social care.
I think you say in your statement that pre-pandemic there were around 90 staff in the Care and Transformation Directorate where adult social care sat, but that grew to 319 odd personnel, and hence that might feed into perhaps some of the more fast-moving and perhaps less structured response at the beginning. Can you help me now with the size of the ASC team as we are today in 2025?
I think it's 310.
And is there any capacity or plan in place if there needed to be an expansion of those numbers?
I mean, not explicitly, but there's lots of capacity within any government department to flex. So I think from a decent size of 300, that's a good starting point.
Perhaps to help you as we go through your evidence, I just want to summarise some of the numbers involved in the adult social care as at March. And I think you say in your statement there were 15,525 care homes in England, the majority of which were not nursing homes. There were 450,000 odd beds, not all occupied, but estimated occupancy was just under 85%. There was just under 10,000 home care agencies, 1.2 million posts for workforce, with about 112,000 vacancies, we understand it. And depending on which definition you use, certainly in the 2021 census, approximately 4.7 million unpaid carers. I just thought that context might help as we go through. Now, can I just ask you about unpaid carers? Because Mr. Hancock gave evidence last week and told us that there were policy around unpaid carers was difficult because of definitional issues, to use his phrase. And I think Miss Keegan, who was in the department, said that there was no robust system for identifying unpaid carers, and she thought that if there was a better system for identifying them, then they could have been better supported. So just your reflections, please, Ms Dyson. And obviously it's difficult because who is an unpaid carer might depend on whether you provide 1 hour, the circumstances, whether you're doing it effectively as a full-time job. But is there any work being done to try and define unpaid carers to help in the event of a future pandemic?
I felt we did some very good work on this around the vaccines issue, because unpaid carers were prioritised. I believe they were in Group 6 for vaccines. And so we needed to identify them at that point. And the work that we did was about looking at the GP record, because GPs have records of unpaid carers, and the DWP record from carers allowance. I think there are about 900,000 people or so on carers allowance, and local authority records on carers. And then we worked with Carers UK to see if we could sort of develop that list further so that we were sure that we were not missing people. So that was really quite innovative work, led from the department's point of view by David Pearson, working with Carers UK to try and get to that list. And so is there now a list of unpaid carers? I'm not suggesting it's going to be perfect by any stretch of the imagination, but if we wanted to in July 2025 look at how many the department thought were unpaid carers, would we be able to find that number easily? I mean, not to my knowledge. We rest on the ONS data that you mentioned, the 2021 data. Right. I'd like to start with a few questions, please, about pre-pandemic preparedness. And there are a number of groups set up to address this. But can I have your assistance, please, about what is called the Cross-Government Pandemic Flu Response from April 2017. And could I have on screen, please, INQ 40222748. Now, Ms Dyson, I'm conscious that obviously you weren't in the department in 2017, but I think you have had a look at this document in preparation for giving evidence. And we can see the second box there deals with the outline work plan. And the objective was to achieve an appropriate capability to provide adult social care in England during a severe pandemic. And as we go across the row, there is reference at point 2 in the middle column to reviewing existing plans for providing community-based healthcare for patients who would ordinarily receive inpatient care.
Can you help with who those plans were held by or should have been held by?
So I believe this point should have been directed, and maybe was directed, towards NHS England, because this is about community-based healthcare as opposed to adult social care.
So this would be not necessarily, we can see DH and DCLG, presumably DH was the Department of Health,
Yes.
as then called, and the former, I think it's, what is it, Ministry of Local Government now. So this could be essentially at aimed at a number of different departments or organisations to help bring together a cohesive plan for adult social care. Can we go over to the third column? Because there's what are set out to be said, the deliverables, and there needed to be an adequate means to measure and monitor adult social care capacity, which is clearly something that was partly responsibility of the Department of Health, a capability requirement, a range of policy and practical options, an overarching plan, and then again, potentially policy and practical options for the patients who would ordinarily be treated as inpatients in the community. Can you just help me? What plans arose as a result of this outline work plan?
So I think it's just by way of sort of context important to remember that adult social care is a locally run system. So when you're talking about planning, you're thinking about, yes, what the department is doing, but more so, at least at this point in time, what is happening locally. And it was always assumed that a pandemic would be run by the local resilience fora with the department supporting, but the response would very much sit at local level. As I see these actions, they're very much focused on, is there going to be enough capacity in adult social care in the event of a pandemic? So will there be enough care home beds? Will there be enough home care capacity? And will there be enough staff to support them? The things that happen that I'm aware of as a result of these actions is, first of all, there's some really quite detailed policy work that is done within the department. I've seen the paper that was written in 2018, which looks at things like workforce shortages, it looks at things like hospital discharge, it looks at how you would prioritise local government services in the event of a worst case scenario. The other thing that's going on in the department at this time, maybe not so related to this, although indirectly it is, was the work on the coronavirus, what became the Coronavirus Act, because it's related to this because of the care easements part of that. And then, so that's what happened within the department. Separately from that, the department commissioned ADAS, that's the Association of Directors of Adult Social Services, to do some work on all of this. And again, I've seen what they did. They did a big survey of local government. They produced a sort of suite of products that looked at how you would do statistics at a local level in the event of a pandemic, how you would do communications at a local level in the event of a pandemic, how you try and recruit volunteers, and then they produced some guidance.
Can I ask you about the work being done with the local authorities, though, given that answer you've just said, a lot of the planning lies essentially with them. And I think you said in your statement that adult social care was fully incorporated into pandemic planning, but you did say that there were some challenges that were identified. And could you just help us? What were the main challenges as the department saw them with the pandemic planning?
I mean, I don't recall that paragraph precisely and exactly what it was getting at, but I mean, there is an underlying issue in adult social care at this point in time, which is was being flagged, which is the fragility of the system. That there were workforce. You already mentioned there were sort of significant vacancies in the workforce. There was a real concern about whether the funding going into the publicly funded part of adult social care was sufficient. The department was doing a lot of work on looking at the potential for major provider failure. That is, a sort of big care home provider could fail, and there was sort of contingency planning going on around that.
Can I ask you something about that answer you just said there? You spoke about the fragility of the system, and you're not the first witness, Ms Dyson. I dare say you won't be the last. Underfunding and a workforce that is there is vacancies and indeed a retention problem, as we understand it. A number of witnesses have spoken about that, but no one has as yet sort of said what the department has done or across government has done to try and address those issues. It's sort of an acknowledged problem, but where's the solution, or who was trying to solve it as at the time of January 2020?
So, I mean, first of all, I think we should just get it in context. I mean, there was a funding issue, and that had been particularly between sort of 2010 up to 2015. Actually, quite a lot of money had gone into the adult social care system from 2015 onwards. The vacancy rate, I think it was 8% at the time.
Yes.
I mean, you can have care homes that are growing, so they would then be flagging vacancies. It's not necessarily a problem. We now measure actually the size of the workforce. So alongside the vacancy rate, which is measured by Skills for Care, we internally measure the size of the workforce to see how much it's growing or otherwise. But I don't underestimate. There is an overarching problem, but I just don't want to get it. We had very significant workforce problems during the pandemic. They weren't so significant at this point in time. In answer to what are we doing about the fragility, I mean, the government has appointed Baroness Louise Casey to do a independent review into adult social care, and that will no doubt look at these issues.
You mentioned there that the 120,000 vacancies as we were going in. I think there were higher vacancies in London and the South East in particular, and there were predictions that there would be another, I think about 11%, or to put it in old money, 176,000 staff that might be absent due to illness. So clearly, was there a real concern that some of the larger care providers might not be able to provide care, might have to close their care homes? And are you able to give us a sense of the scale of the worry that care homes might have to shut?
So this was very much the concern going into the pandemic, and it reflects the document we just looked at. Would there be enough capacity? In the event, actually, workforce capacity was not the issue. There were many issues, as I'm sure we'll come on to talk about, but it was not the issue in the first few months of the pandemic. Workforce capacity became a very big issue in January 2021, and even more so in the last sort of quarter, the autumn of 2021. That's when it really hit the workforce capacity issues, but not in those first few months.
All right. We'll come back to 2021, if we may. Can I return, though, to the question of planning? Because, and ask, please, to have up on screen INQ 595344. This is some minutes from the National Steering Group that was in existence at that time. And it was on the 12th of February 2020. And we can see reference in that top box to the main headline being for local authorities to revise local flu plans in light of new information and anything that is different for CV. Was that shorthand for clinically vulnerable?
I think coronavirus, I would guess.
Thank you. And these plans can incorporate advice from the centre. And if we just scroll down to the bottom of that page, there's reference to contingency plans. Perhaps we can just, there we are, thank you very much. Is that the same thing as the local authority plans that were spoken about in the box at the top of the page? I don't want to conflate two different types of plans.
I would have thought so, yes.
Right. Given that we are dealing here with local authority plans, clearly there was in February a plan to revise them, and indeed, is there anything DHSC can do to assure that local plans are robust? And someone comments that LGA and ADAS neither of them have the assurance skills. Local authorities are accountable to members and population, and the assurance role sits with its members. They can help, perhaps work on a checklist with questions to ask when checking the plans are fit for purpose, so that the local resilience forum can be confident. And that was agreed by another member of the committee. Are there plans for all local, have they been refreshed? Could we share best practice if we know of a good quality plan? And I think you're aware, Ms Dyson, that in due course, Minister Helen Whately asked for a number of local authority plans and received 2, which in her view were inadequate. Can you help with what was done between February 2020, when there were clearly attempts to look at the plans and see if they were robust enough, and then what happened to the reviewing the local authority plans thereafter?
So the plan that there was to use MHCLG, that's the local government department, to help with assurance of plans. I think that was discussed at the Helen Whately meeting in early March. In the event that got overtaken by events, we were quite swiftly, plans were left behind, and we were very much into a full-blown pandemic.
So you're quite right. There was a meeting on the 5th of March where the Minister set out her concerns about the two plans she'd seen, and indeed reference to trying to find a good one that we could then perhaps copy and replicate across the local authorities. When you say events overtook us, does that mean that essentially work wasn't done on checking whether local authority plans were robust enough?
So I wasn't there at the time, so I've been asking questions, and the answer that I have had on this is that the intention was to use MHCLG for this, but my sense is it didn't actually happen because that would have been quite a big deal, I guess, to set up a whole infrastructure to do this, and then the pandemic, was developing very, very fast at this point in time.
That explains the position back then. What about now? What, if any, efforts have been done from the department's perspective to ensure that local authority plans are robust enough, adequate enough, pick whichever word you choose?
So I think that will be picked up in our pandemic preparedness strategy that the department is going to publish.
And when do you know when that is going to be published, roughly?
I'm not sure exactly, but I know that we're planning to publish that, and then alongside it, there'll be 5 plans for each of the 5 different routes of transmission, starting with a respiratory plan.
We may come back to that in a moment. Now, sitting under the local authority plans, though, is it right that providers themselves were supposed to have plans?
Yes, I mean, I wouldn't necessarily describe them as sitting under the local authority plan. I mean, lots of providers don't actually have a relationship with the local authority if they just take privately funded individuals. So they have to have plans. That's part of the sort of CQC requirement.
Can I ask you then, please, about perhaps it's my phraseology, but not the local authority plans, but plans at provider level. Can we have up on screen, please, 595342_2? This is from a coronavirus steering group meeting the following week on the 19th of February. So on the 12th, they've looked at the local authority plans and whether there's assurance or robustness. Here in the middle, looking at contingency plans, we can see we're talking about 19 providers have confirmed their Plan Flu preparedness plan was up to date. Of those, 16 had plans that covered how the organisation could manage if 20% of the staff were absent, and 3 providers had plans to cover staff absences, but this did not extend as far as 20%. Now, can I just ask, in ordinary times, do provider-level plans, are they something that is ordinarily looked at by the Department of Health?
No.
Right. And you mentioned there the CQC. We can see 2 of those 3 providers expressed an interest in further guidance from the CQC on how to prepare for the event that only 80% of the staff were present. And it looks like was going to be a CQC review, or you were going to ask the CQC to, sorry, had they done one, or were you going to ask them to do one?
I don't know the answer to that. I mean, I would just say that this looks like a sort of small dip sample. You've got 18,000 registered providers. This looks like a small dip sample, and I can't see how we could possibly have asked the CQC to get into reviewing plans at scale at that point. I mean, obviously, what we did do was we put out guidance on the 25th of February about sort of pandemic preparedness, not particularly on this issue, but just more generally.
The National Steering Group minutes that we've just looked at for a couple of weeks worth of minutes was replaced by the National Adult Social Care COVID Group on the 6th of March. And could you help Ms Dyson with why was the NSG stood down and the Social Care COVID Group stood up?
So the NSG was a standing group to deal with big issues of this kind. So it had looked at Brexit, it was looking at the major provider failure issue that I mentioned before, and then it was looking at COVID in the early days, but it became clear that you needed a very focused group, and hence why the new group was set up, which was jointly chaired by Ros Rawton, who was my predecessor, and by James Bullion from the Association of Directors of Adult Social Services.
Now, that social care COVID group in due course lasted until the task force was set up. And again, why was there the change 3 months later to set up the task force?
So I think the task force was really quite different in kind.
Right.
So that was about bringing in an outside expert, David Pearson, from the sector, to lead a really sort of significant piece of work to implement what had already been put out in terms of action plans, but also to prepare us for winter, because everyone knew that winter was going to be difficult.
Can I turn, please, to some questions about the March 2020 hospital discharge policy? And you say, in fact, part E of your statement, I don't need to turn it up, that the discharge policy was a key priority for NHS England, and that throughout the pandemic, the department worked collaboratively with NHSE and indeed Public Health England to create and implement the policy. And I just wanted to ask, can you help? I know you weren't there, but what did actually the department do to help implement the policy?
So obviously there's the discharge guidance that goes out on the 19th of March. The department would then have been communicating with local government, because when you discharge people from hospital, there's the sort of NHS side of it, but obviously there's the local government and provider side of it. So the department would have been, you then have the 2nd of April guidance, which is very much also about these issues.
Yeah. Now, a lot of those policies, though, effectively were driven by PHE and the advice about who should isolate and the testing and what PPE was needed. Obviously, the department co-produced or co-published them, but is there anything in particular that you can point to the department did to help implement them, aside from issuing the various iterations of guidance that we're aware of?
I mean, Capacity Tracker sort of almost came into being at this point in time. So this is the tool that 50%, I think, of the sector already used as a way of, so this is of the care of providers, they already use this as a way of flagging what vacancies they had in care homes to support hospital discharge. But at this point, from the end of March, beginning of April onwards, we said, essentially we said this is obligatory, please fill in Capacity Tracker as a way of supporting all of this.
Now, we might look at the Capacity Tracker in other respects, but as I understand it, the tracker, it's not mandatory to fill it in. Is that correct? We've heard that perhaps some funding was dependent upon the provider filling in the tracker, but do you know, is there sensibly any way that the department could make data returns to the Capacity Tracker mandatory?
So we have done so now, and that stems from a direction that was given in 2022. When we first started using Capacity Tracker for these purposes at the beginning of April, it wasn't mandatory, exactly as you say. We then tied it to the Infection Control Fund, which went out in May the 15th, 2020, where we said, here's £600 million, which 75% of it must be passported on to care providers on a per beds basis, but only if those care providers are filling in Capacity Tracker. And I believe that by June, we were up to about 98% compliance with Capacity Tracker.
Absent, though, the kind of financial incentive to fill in the Capacity Tracker, is there now any work being done to make sure that the Capacity Tracker is filled in and kept up to date? Does DHSC monitor that?
Oh, absolutely. I mean, as I say, it is a requirement now. It's a legislative requirement. They have to fill it in once a month, and we publish some of the data from it, I think, on a quarterly basis.
On a quarterly, did you say?
Quarterly, I think.
Thank you. I just misheard you. All right. In your statement, you refer to a Social Care Institute for Excellence report on some of the challenges and solutions about commissioning social care. And if it helps you, Ms Dyson, I'm at paragraph 203. But that report highlighted perhaps some of the limited options for care facilities, making it challenging to avoid placing patients in care homes that have been rated as inadequate. Does the department know how many people were discharged from hospitals to care homes rated as inadequate?
No, we don't. I mean, it's worth saying, though, that the next paragraph of my statement there does talk about CQC support for care homes that needed improvement or were inadequate. And the other thing to remember in all of this is that the local authority has an important role. They really, they are obviously experts in adult social care, but they also have a statutory duty to manage their care market, which means that they really know their care providers, and there might be issues that they would be aware of that hadn't been flagged by CQC. So, for example, it might be that the improvements that were needed that CQC had flagged, they might have taken place, but CQC might not have gone back, or the local authority might have done its own assurance to make sure that it was a suitable place for that person.
I understand all of those additional context, but do you think the department should know that if it has to discharge people to care homes rated as inadequate for whatever reason, whether that's fundamentally care issues or perhaps some kind of governance issue, do you not think that the department should know that there may be potentially discharges to care homes that have a lower rating?
So I think fundamentally this is a local authority issue, but we've now introduced what is effectively CQC inspection of local authority Care Act duties, and it may be that that is where this should be looked at rather than sort of collating data at a central government level.
Later on in the pandemic, we know that there was the designated settings policy, and indeed I think the plan was that there was to be a 14-day isolation in specific care homes that had been approved by the CQC as having the requisite isolation facilities. And every local authority was to have at least a setting where the designated accommodation could be utilised. And you say in your statement at paragraph 249 that during the second wave, there were 159 approved designated settings, providing 2,169 beds. And I think at the time in January 2021, when the policy came in, about 37%, there was a 37% vacancy rate. Does the department know how many people were discharged to designated settings, or is that something again for the local authorities or the CQC?
I think we do know how many people were discharged into designated settings. I mean, it's worth noting that it was always possible also to discharge someone into a normal care home if that care home felt that they could take the person, and that might well be a better solution. You know, if you could be discharged back to your own care home, that would be better than going into a designated setting. So the designated settings were, I don't want to say last resort, but just a fallback. So if there were vacancies there, that was okay, as long as people could be discharged safely.
I think in due course the dashboard had data about designated settings and the number of beds that were being utilised. There certainly did become that data available. Generally, though, in relation to the designated settings policy, I think you say that the department considered it to be a success and a policy that would be considered in the event of a future pandemic, subject to clinical advice. Can you help Ms Dyson with why the department takes the view that that policy was a success and why it might be considered again?
I mean, it was important to be able to discharge people safely. As I say, it was better if they could be discharged back to their own care home. But if that was not possible, if that care home didn't feel that they could safely care for that person, then it was important to get them out of hospital, because we know that being in hospital is not a good place for people who don't need to be there to be. And so this was a way of achieving that.
You said, however, there were concerns about designated settings which are recognised by the department, not only a limited number of available, but the placement may be less tailored to the specific needs of the person being discharged, and indeed it may be geographically nowhere near their friends or family. You say the department doesn't hold data on the designated settings policy on infection rates. or morbidity and mortality. Do you know, does any organisation or department hold that data? Because if we're sending patients to a designated setting with the idea that they are isolated and safe, doesn't one need to know that there isn't an infection in that home and we're not bringing in an infection into that home?
I mean, I would have thought that we could get that data because we were able to see by every care home we could see what was going on in terms of infection rates in every care home across England, and that would apply equally to care homes that were designated settings.
Do you know whether there is any work being done to ensure that designated settings remain available if needed? Because it took clearly a number of months to set up the designated settings policy, but in the event of a future pandemic, is there a plan in place to be able to quickly roll out a designated settings policy?
So I'm sure we could do it again. The things that you needed to make it work, well, we needed the funding that came from the discharge funding that NHS England had. You needed each local authority to identify a place. You needed to get the infection prevention control right in that place. You needed CQC then to assure it and sign it off. So I'm sure we could do all that again.
I'd like to ask you some questions, please, about restricting movement of staff between care homes. And if it helps you, I'm at paragraph 461 in your Part C statement, Ms Dyson. But as the inquiry understands it, the Infection Control Fund, which you've already mentioned, was designed in part to be used to prevent transmission by paying the wages of staff who were isolating and trying to ensure, so far as possible, that members of staff only worked in one care home. That's a fairly broad summary, but not an inaccurate one, I hope. Can we just have a look, please, at the INQ 325-286_32? This is an annex from admissions guidance from August 2020. And if we can see the bullet points there, they set out a number of ways of trying to prevent the spread of the virus. There you've got ensuring that members of staff only work in one care home wherever possible, extending those restrictions to agency staff, limiting or cohorting the staff, and if additional staff are needed to restrict movement between or within care homes, to actively increase recruitment of staff. And then there are various other steps set out there. Inquiry is aware that there were possible legislative restrictions being considered by the Department and indeed the Secretary of State, but that the consultation that was announced was overwhelmingly against bringing in any regulations to restrict staff movement. In your statement, you say there was a proposed compensation scheme to try and ameliorate some of the financial difficulties that staff may face if they were restricted in the number of homes they could work at. But that was rejected by HMT at the time. And we know in due course legislation didn't come in, but there was the Infection Control Fund and a number of tranches of that funding. I suppose it's a rather big question to answer, but in the event of a future pandemic, what's the department's thoughts on how best to restrict staff movement if that becomes necessary in a future pandemic?
So just to make one overarching point before I get into that, which is, I know there's been an awful lot of focus on staff movement, but actually just staff moving from the community into care homes was a really big issue, and that's why when you look at this list, the final point on the list about would there be staff who would actually be prepared to move into a care home, that would really help. So even if we could have eradicated staff movement, you would have still had the issue, the obvious issue that staff would be moving from their communities into care homes, and what we saw throughout the pandemic is as soon as there was transmission in the community, then it would follow. It would come in through care homes. In terms of should we restrict staff movement in the future, I mean, what we did do, as you can see here, and actually this list is from August, but it was, I think the identical list was there earlier as well. And this list also, as you said, went alongside the Infection Control Fund as these are the sorts of things you should be spending money on. And then we put out a lot of guidance saying, please don't do staff movement. I think we went a long way to reducing staff movement even without legislation. So, for example, I've taken this from the task force report. On the 29th of May, 78% of care homes were saying that they were restricting staff movement. That was in Capacity Tracker. By the 20th of July, 92% were saying they were restricting staff movement. So we went a long way to restrict, people understood the importance of restricting staff movement. We gave them guidance on that. We gave them the money to do it. We could see in Capacity Tracker what was going on. And so where we were concerned about staff movement, we could use the regional assurance team that we built up in the autumn to make phone calls to care homes to say, if they still seem to be doing staff movement, can you think about maybe restricting it? So, I mean, I understand why we thought that legislation would be a good thing, but I think we went a long way to sort of reducing, I can't say eradicating, but massively reducing the practice. I mean, of course, the thing that went against us was staff shortages.
Yep.
And that it was in the end, that issue plus the compensation issue was why we didn't go ahead with the legislation. 68% of people who responded to the consultation said that they would have to make an exception every week to allow for staff movement because otherwise they wouldn't have safe staffing levels. So I think we went a long way without legislation, and our focus became on what can we do to address the workforce shortages. And we put out a workforce capacity fund in January 2021 of 120 million to support those staff shortages.
Doesn't that come back to if you enter the pandemic with staff shortages and a fragile workforce, it's going to be exacerbated by this? And however you want to try and do it, if you can't legislate, there's still going to be that tension between restricting staff movement to prevent the infection spread, but equally not having care homes not being able to run because they don't have enough staff in them. What I suppose it comes back to is how now are we going to increase the resilience or in the workforce sector? Can you help with that?
So we're passing some important legislation at the moment on the Fair Pay Agreement, that is paying care workers above minimum, creating a new wage for care workers, and clearly, particularly in towards the back end of 2021 when we lost a lot of care workers to the retail and hospitality sectors, that was because of pay. So I think that will help. There's a big move to professionalise the care workforce and to recognise their amazing professionalism, because what they do is incredible, but to recognise it in terms of the qualifications, etc. So I think all of that will help. And again, I would expect that Louise Casey will want to look at this.
Can I ask you about recognition? Because her ladyship heard from a witness this morning who represented unpaid carers, who spoke about the need for the unpaid carers workforce to be recognised. Can you give us any more details about what work is being done to recognise the contribution, not just unpaid carers, but of the adult social care sector workforce?
Look, I think this will be a Baroness Louise Casey issue. I very much recognise it.
Back to restricting staff movement, can I just take you back then to the question that I asked before we dealt with some of the other matters, but what are the department's thoughts on how best to restrict staff movement in the event of a future pandemic? Does it rely on having a fund available to allow them to take taxis, allow self-isolation on more pay? If it can't be legislation, what's the solution?
I think it could be legislation, but I would almost start from further back. We're assuming that staff movement is the issue. as I said, I think in this pandemic, staff movement was a part of the issue, but there was a bigger issue about how to prevent the virus coming in from the community into care homes through staff, and there might be different issues in a future pandemic, but I wouldn't rule out if the issue is staff movement in a future pandemic, I certainly wouldn't rule out legislation. I think we came very close to legislating. The two reasons why we didn't was one was the staff shortages at that point in time in particular, and also the fact that the Treasury didn't agree to a sort of ring-fenced fund to support care workers who would lose one of their jobs.
One of the matters that we have considered is whether it's possible at all to restrict staff movement in the domiciliary care setting when workers clearly may be visiting a number of different houses and different people that have care needs every single day. Do you, on behalf of the department, think that there does need to be work done to try and address the risks posed by staff movement in the home care setting?
I mean, the proposals we had on the table did cover the situation where someone moved from a home care setting into a care home, but not where they moved from one home care setting to another home care setting. And the reason we did that was because care homes were so particularly vulnerable in this pandemic to the virus because of the people who were living there and because of the way in which the virus transmitted within the care home. People who were living in their own homes were less vulnerable to COVID. There were fewer people there, and you didn't have this issue about the virus sort of transmitting so easily within the setting.
Did the department take any steps to try and address staff movement by domiciliary care workers from home to home, not care home into a home care or home care into a care home?
Not explicitly. I mean, of course, we introduced testing for domiciliary care workers, which would have helped on this.
You mentioned the role of the Infection Control Fund. Can I ask you about that? It was, I think, £600 million, you said, ring-fenced to tackle the spread of COVID-19. And clearly, the providers had to complete the capacity tracker to be eligible for the ICF funding, which Mr. Hancock described as a lever of sorts over the sector. And I think you said in your statement that the department asked all local authority chief executives to provide a return which outlined the allocation of funds to care homes as well as what it was spent on. And you say in your statement local authorities had taken different approaches as to how they used the money. But the National Care Forum are concerned that roughly home care was relatively underfunded relative to the need. Can you help with what, if any, part of the ICF, Infection Control Fund, was meant to be spent on home care?
So in the original Infection Control Fund from May 2020, 75% of it had to be and this was the innovation, that you were giving money to local authorities which had to be passported through to care providers. 75% of it was passported through to care homes on a per beds basis, and then the remaining 25% was for the local authorities to use, including for home care. Right. In the next version of the Infection Control Fund, which was in the autumn, which I think might have been 586 million, that was the percentage that had to be passported through was increased to 80%, and that went on both a per bed and a per user basis. So it had to be passported through, as I understand it, to both care homes and to home care providers. So they should have got more money from that point onwards.
Do you know why in the initial round of funding it was deliberately decided that 75% of it was to go to care homes on a per bed basis?
Well, I suppose if you think about the sorts of things we were saying that needed to happen with it, if you look at the list we were looking at before, it was about some of the things would apply only to care homes. For example, cohorting to floors or wings, ensuring that members of staff only worked in one care home, providing accommodation to staff who chose to move into a care home. So a number of those things were only for care homes, but I accept that some of them were for both care homes and for home care.
May I ask you this, Ms Dyson? There's a perception, at least, that always home care was a lower priority than care homes. Sometimes it's been said as being an afterthought. That might be pejorative to some, but you understand the sense I'm using those phrases. Was there a sense in the department that there was less priority given to home care?
The risks were greater in care homes than they were for people living in their own homes. So hence why regular asymptomatic testing was rolled out for care homes from July onwards, but only for NHS staff and home care staff from November. I think it was just consistent, and the same with the vaccine. It was just consistent with the scientific consensus on where the greatest risks lay.
Clearly, one of the ways of preventing the spread of the infection would be by use of PPE. And so can I ask you about that, please? The inquiry is familiar with the supply shortages that were extant as at February 2020. And we know that the stockpile, the pandemic influenza preparedness stockpile, did not contain gowns, for example, and there was a worldwide shortage. So please take that as a given. Clearly, by the 13th of March 2020, there was a huge demand for PPE within the NHS. And as far as care homes were concerned, PPE was to be worn by care workers if the resident had symptoms, but no PPE needed to be worn if the resident or the worker were not symptomatic. And then there was various iterations thereafter of the guidance, which did end up asking for more PPE to be worn. But can I ask you, please, to have a look at on screen INQ 587777_23. It's from your actual statement, but it's some of the steps that the department took to try and meet the needs of the care sector in terms of PPE. There was a one-off direct supply to CQC registered care homes using the stock from the stockpile. Was this in part the issuing of a number of face masks to the care homes that happened in mid-March of 2020, do you know?
Yeah, this was what happened on the 13th of March when every CQC registered provider got at least 300 face masks.
Right, that is what we're talking about here. All right, and can I ask you about that, please? Clearly, one doesn't want to sniff at it, but NACAS in particular, or a member of NACAS, has commented that 300 masks don't go very far if you've got 50 staff members. Do you know why 300 was lighted upon? Was it simply that was all the stock there was to supply at that time?
I imagine that was the answer. I mean, it's worth saying that the emergency response, that the number B on the list here, that was stood up on the 16th of March. Yep. So these other steps happen really quite quickly after that.
We'll look at some of those. That one-off supply of the mask, though, as it sets out there, was only to care homes. Do you know whether there was any thought given as to whether there ought to be a one-off supply to people working in domiciliary care?
I don't know.
Right. There was the paragraph B, an emergency response of PPE when a provider had less than 3 days' worth of PPE remaining. And I think in your statement you say that on the 16th of March, the National Supply Disruption Response Hotline, NSDR, was set up. And providers could obtain emergency supply. And in fact, there was such demand that it had to become a 24/7 hotline. Is that correct?
Yes.
You say in your statement that the department is not aware that that hotline could not meet requests, but data available for the week commencing 6th of April showed that there was daily over 1,084 daily contacts to that hotline, and by far the largest number of requests came in March to October 2020 from the adult social care sector. Is that right?
I mean, that sounds right. I know that the biggest adult social care providers on the whole, continue to be able to buy their own PPE, and it tends to be the small providers, which would be the large numbers who were calling. I mean, it's worth saying that in the first full week of operation of this hotline, over 500,000 items of PPE were dispatched.
But it was meant to be an emergency response there for that hotline. So just standing back from the emergency, where you're down to your last 3 days' worth, can you help, please, with the point E there, developing a new direct small volume distribution channel for PPE, the e-portal or the PPE portal? Was it also known as the Clipper system?
I think that was one of the logistical providers behind it.
And help us, Ms Dyson, what was the aim of the PPE portal? If it helps you, it's at paragraph 121 in your Part C.
The aim was to just get PPE onto a sort of sustainable footing. So these other, we shouldn't neglect paragraph C and D, which were also very, very important in sort of April and May. But from June onwards, we got the we started with the small providers, registering them on the e-portal because, as I say, they were the ones we knew who were having the most problems. By September, all social care providers were registered onto the portal, and this became the way that everyone got their PPE. I mean, I should say I arrived in the department in September 2020. Yeah. PPE was not an issue that was sort of loud and red and flashing on my agenda from that point onwards. So it's clearly been a very big issue in the early part of the pandemic, and I really feel for providers, the fear they must have had with the pandemic spreading and not being able to get PPE. But by the time the portal was up and running, I think that worked well.
I don't want to misunderstand you. Are you saying that the portal was deliberately rolled out in such a way as to prioritise the smaller providers? Yes. Because it was more difficult for them to obtain PPE in bulk?
Yes, we knew that they were struggling more.
I say that because the LGA are slightly critical of the absence of larger providers being able to get onto and register for the portal. But it sounds to me like that was a deliberate decision by the department to try and help the smaller providers that were struggling.
Yes, and the large providers, everyone was on it by September.
Earlier on in the pandemic, before you joined the department, though, there was reports received by the department that PPE was being diverted to the NHS. I think you're aware of those reports, Ms Dyson. Is it correct that there was no policy from either government or indeed the NHS that such supplies should be diverted?
Yes, that's absolutely correct.
Can I have a look on screen, please, at INQ 608140. _ page 4. This is an email from the National Care Forum, and it's, just give me one moment, 9th of March 2020, and the Nader Ahmed of the National Care Association, has emailed the Department of Health. Can we have, thank you, page, perhaps my paging has gone slightly awry, but there is reference in the email to the Department of Health where there is the National Care Association are aware that suppliers are only supplying hand foam and hand gel to the NHS. A government directive apparently says the email, although clearly that's not correct. If that's true, it's outrageous, and they're bringing it to the attention of the department. You've dealt with the fact that there was no directive, certainly as far as the Department of Health is concerned, but can you give us an idea of the scale of concerns that were brought to the department's attention about supplies going to the NHS over preference to adult social care?
There was a lot of anecdotal evidence of this at the time.
And do you know what the department did to try and correct the misapprehension that there'd been a directive in this regard?
I mean, so we were very clear that it was absolutely not the policy. I noted that in the 2nd of April admissions guidance, there's a statement in there to that effect. I suspect there may have been other statements that I haven't seen, but because it very much was the case that we wanted to put matters right on this.
Has the department done any, or did the department try and understand where the misapprehension had come from? Was it something that suppliers were taking the decision themselves? Do you know where this has sprung from?
I mean, I have heard speculation that it might have been wholesalers who reached that, but I really don't know.
Right. And in relation to PPE and unpaid carers, we know that the initial advice to unpaid carers in April 2020 was that face masks were not recommended unless advised by a healthcare professional. And I think you said in your statement of paragraph 142 that the Deputy Chief Medical Officer and indeed Public Health England's advice was that unpaid carers should not use PPE while providing care. They were concerned that unpaid carers would not use the PPE properly, and that without direct training and supervision, it could create additional risk or a false sense of protection. Do you know why there wasn't training rolled out to unpaid carers at that stage, as there was later on in the year via various online resources?
It wasn't felt to be necessary at that point in time. And then when we looked at it again in July, by that point, the rates of COVID were very low, and so it really wasn't felt to be necessary then. So SAGE was commissioned to look at the issue for the purposes of the winter, and then it was taken forwards in the autumn.
I think either DCMO and or Public Health England were also worried about supply issues. From the department's perspective, was the supply issue the dominant reason for this advice, or was it concern about false reassurance and inappropriate or lack of training in PPE usage?
I mean, it never came to a head in May. It came to a head in July, by which time the conclusion was we don't need to do this at a time when rates of COVID are so low.
Thank you. In September of 2020, there was a pilot, I think following advice from the SAGE Social Care Working Group, to roll out free PPE for unpaid carers. And I think in January 2021, it was then rolled out nationally just to help you. Can we have a look, please, at the results from the pilot at INQ 110355? So this is the pilot that started in the autumn of 2020. And the outcomes of the pilot showed that demand had been low, with under 50 carers accessing PPE in each pilot location. Local authorities have not required a substantial amount of additional PPE to enable them to provide this group. And then if we just go down, you can see some of the figures there. The highest figure we're aware of for distribution to extra resident care, unpaid carers, i.e. those that don't live with the person they're caring for, is 256 in Birmingham in the month of July. It did rise sharply to 1,300 odd carers in November when they extended it. But on any view, these are small numbers of PPE being rolled out to 700,000 odd, 5 million odd unpaid carers. Potentially. Do you know whether there was the low demand was because there was difficulty in identifying unpaid carers and therefore letting them know that there was free PPE?
So I don't know why there was a low level of demand. And we did this through local authorities who would, even if they couldn't reach all unpaid carers in their area, they would have had reach to a higher level, higher numbers than this level of demand would suggest. So I don't know why the level of demand was low. I note, though, that it was low in other nations as well, and Scotland, etc., but we never really got to the bottom of why it was so low.
Do you think it might come back to the problems with defining who they are, therefore identifying them, therefore notifying them, and then getting PPE out to them if the unpaid carer needs it?
I think it could do, but I think that local authorities would know more than, say, 50 carers. Any given local authority would know more than 50 carers in their area. So I think it's more than that that's going on here.
Was there an issue with the amount of publicity that the rollout of free PPE to unpaid carers garnered?
Possibly. I think we did some work on that, but possibly As I say, it's interesting that the same issues arose in other nations who actually did this earlier. So I can't.
That
I
was
don't-
my final question on
Right.
this topic. Do you know why it was that England didn't roll this out earlier than some of the devolved nations did?
Well, as I say, it was looked at in the summer. It was concluded that it wasn't necessary because rates were so low. Then it came back in the autumn. We did a pilot. It was important to pilot this to see what the level of demand was actually going to be, whether we would in fact have the stock that was needed. And then it was rolled out in January 2021. I think if you can see as you look through the papers how this unfolded.
And what plans, if any, exist for rollout of PPE to unpaid carers in the event of a future pandemic where they need PPE? Is there any kind of plan that's ready or being formulated?
Look, we're looking at PPE as a whole in terms of pandemic preparedness. I don't know explicitly on unpaid carers.
Miley, may I just deal with a couple of topics perhaps before our mid-afternoon break? One of the matters that you've already referred us to, Ms Dyson, was the problems with capacity within the workforce. And I think you mentioned there was a workforce capacity fund that was set up. It's not the only thing the department did, but I'm not going to ask you about all of the steps the department took. Could you go, though, please, to your paragraph 391 in your statement? Because you say there that the department had 4 objectives to address workforce challenges: ensuring the sector had enough workers, supporting the workforce, protecting the workforce, and then indeed protecting the recipients that the workforce looked after. I'd just like to look at a few of those with you.
Could I just interject for a minute?
Certainly.
So I as I said here, it's for the purposes of this statement, this was me creating those 4 categories for the purposes of the statement to try and sort of...
To bring them together.
To make it logical, because there was so much activity on workforce, I felt it needed to be broken down. I wouldn't want the inquiry to get the impression that this was these categories were how we approach things.
No, thank you. It was your attempt to draw the strands together in an intelligible way for us. Understood. Thank you very much. And bearing that in mind, clearly attempts to increase workforce capacity included a rapid induction training scheme and fast-track recruitment. I'm not going to ask you about those. But the Workforce Capacity Fund was announced on the 16th of January 2021. And it was £120 million ring-fenced, designed to increase the use of the existing workforce and increase the size. And there was a review, as I understand it, of that fund. And in total, I think you say that 39,000 odd staff were recruited. Can we have up on screen, please, INQ 279947_14. And the section there, what do stakeholders think? In the review, stakeholders welcomed the fund being provided to mitigate the workforce capacity issues, but said it came late. The guidance and the grant conditions being announced on the 29th of January, and the first tranche of funding not being paid until February 2021. Stakeholders believe that if funding had been provided as part of the winter plan in September, it would have reduced the risk of a small number of cases of COVID-positive staff continuing to work in care homes. Do you know whether any work has been done or is being done to speed up the time taken to get money on the ground to those that need it? I mean, on any view, 29th of January into February is not the most inordinate delay, if I can put it like that. But clearly, the feedback coming back to you was there was still, nonetheless, this was all a bit too late to help with the pressures over that winter. Can you help with that at all, Ms Dyson?
So the issue that they're complaining about, I think with justification, is that this was money that would run out at the end of March 2021. So they've got very, very little time to spend it. And they were asking for it to come much earlier. And the reason why we didn't put it out early, we didn't get agreement from the Treasury to do it until this point. So that when we did I think it was called the Workforce Recruitment and Retention Fund, a sort of similar fund in the following winter, that went out in October. So that was better. But I know that local authorities would like to have long-term funding, not these sort of short-term injections of funding, because it's difficult to recruit staff. I think these funds were most useful in terms of retaining staff, or, for example, paying for childcare so that someone could work for further hours, an existing member of staff could work for more hours. It's difficult to recruit lots of people when you've only got money for a short space of time.
And perhaps just finally before the break, one of the things you said very early on in your evidence was actually there was real problems with workforce capacity later on into 2021. And I'd just like to look at that with you. And could I have up on screen, please, INQ 111776, because you say in your statement that pressures were acute in 2021 into 2022. And this is an email from the 8th of September. It's from Vic Rayner of the National Care Forum, coming into various people in DHSC. And in the body of the email, Ms. Rayner says, I'd like to arrange as urgently as possible a meeting with one of our members who'd be willing to talk through the immediate crisis they are experiencing. They are seeing a very significant deterioration in workforce over recent weeks, with large-scale absences and departures of staff. It's very different to where we were a few months ago, where there was relative stability. They attribute this to a number of core factors: total burnout and exhaustion from the last few months, growing levels of mental health, poverty amongst the workforce, triggering departures for better paid work, presumably that's even departures from workers with a strong affiliation to care and vaccine as a condition of deployment. Everyone within the organisation is having to work down, with senior managers, local managers and everyone having to turn their hand to delivery. Agency staff are not available. Local authorities are calling on them for help rather than being able to offer help. And essentially that provider who was reporting this to Ms. Rayner, who's reporting it to the Department of Health, is asking for a Chatham House discussion. In that email, at the top, there's a reference to the data, and indeed she says it at the bottom there. I understand the data tells a different picture. And I wanted to ask about the disconnect, potentially, between what the data was showing in September 2021, or the autumn, and the very real crisis that Ms. Rayner's speaking about in this statement. Do you know what the data was showing and why there is potentially a disconnect?
I think this goes to a really important point that in terms of, sort of recommendations, because everyone talks about data. Data really matters. But some data, this data, is retrospective. So workforce data. So we didn't know from our data. It appears, and I think this was right at the time, we didn't know the scale of the problem, but the way we found out about the scale of the problem was through our very extensive stakeholder conversations. So in my view, in order to stay abreast of things that are going on in this very, very large and sort of disparate sector, you need two things. You need data, but you also need intelligence. And those who represent the care providers are a brilliant source of intelligence for the department, because they hear instantly when there are problems on the ground. So this email from Vic, it represents exactly the sorts of things I was hearing in sort of September or so at this point in time. We understood it to be more than anything about the pull of retail and hospitality at that point in time, because the economy had just reopened and they were paying higher wages than could be paid for care.
We perhaps after the break will turn to trying to support the workforce and deal with burnout and exhaustion. But would that be a convenient moment, my lady?
Certainly. Ms. Dyson, as you've probably been told, we take breaks for the benefit of everyone, but particularly the stenographer, so I shall return at 3:05. Thank you. Ms. Carey.
Thank you, my lady. Ms Dyson, can I ask you please about your paragraph 477 in your Part C statement, and it's on the topic of COVID-19 positive working. Because I think you set out there that in January 2021, the regional assurance team became aware of some staff not self-isolating after testing positive. Is that correct?
Yes.
And it was happening in areas where there were acute staff shortages and limited alternatives to safely staff care homes. So the decision was made to work when positive rather than not, to try and mitigate those staff shortages. Is that it in a nutshell?
Yes, I mean, it was only in a very few number of cases, so it wasn't widespread, but it was certainly seemed to be becoming more of a systemic issue than when we first found out about it. We thought there was a one rogue case, but it was clear there were a number of them.
Yes, in due course, you wrote an email, I think, that was going to go to the Minister, that you asked Chris Wormold to approve or cast his eye over. And in that, you said there were 6 cases that were brought to the department's attention where a COVID positive staff member had nonetheless gone on to work. Do you know whether the scale was wider than that, or was it just limited to those 6 cases? Can you help at all with how widespread this problem was?
I believe that CQC found some more cases. The number 25 comes to mind, but it may not be exactly that but in that sort of order.
And I think in January, on the 27th, there was a joint statement issued by the CQC, the Association of Directors of Public Health, and Public Health England to say that that should not happen. But you go on in your statement to say that the department was considering how best to address this issue, and advice was provided to the Minister to consider the option of police involvement. Can you help Ms Dyson with what, if anything, happened in relation to police involvement in this area?
Our main response here was through CQC, and I remember speaking extensively to Kate Taroney, who was then the Chief Inspector of Adult Social Care, and she was going to convene all her CQC inspectors to make sure we could get the message out as clearly as possible. Ministers were also interested, I mean, down the line, the main thing was to get the message out as quickly as possible in January, and also do what we could to assuage the issues on staff shortages. Ministers were interested also in exploring the police involvement. We looked into that. I think what happened was CQC said it was not for them to refer things to the police. That was not within their statutory powers. But what they did do was they said that they would involve local authority safeguarding teams if they thought that was necessary.
Yeah. I think also the police in due course were said that they would not have the resources to be able to investigate this number of staff taking this action. But can I come back to the fundamental tension here between what was the department's position between providing potentially unsafe care by a COVID positive member of staff or not providing care at all? Did the department have any position on which of the lesser of the two evils should be adopted?
The department's clear position was that COVID positive staff should not be coming to work, and we were doing everything we could to help with the staff shortages. And indeed, I think the message that went out was, if you've got staff shortages, you need to be flagging that locally and relying on mutual aid. I mean, we were putting in the Workforce Capacity Fund, as we've already discussed. We did a big recruitment drive at the same time, but ultimately providers should not be employing people, should not be having people come to work who were COVID positive. They needed to find alternative ways of ensuring safe staffing.
January 2021, when these 6 examples were brought to the department's attention, there was a time where there was rising rates of COVID infection. Was any thought given to how to prevent this reoccurring in winter of 21 into 2022, when again there was other winter pressures as normally exist?
I mean, it was just our very clear messaging. If you're COVID positive, you must not come into a care home, which is such a where the risk of COVID spreading is so high. This is against the law. You mustn't do it.
just before we broke, you explained how you had categorised into 4 sort of neat areas, objectives that the department had to try and deal with workforce challenges. And one of those was supporting the adult social care workforce. I think you say in your statement that the Adult Social Care Task Force recommended a review of wellbeing services in one of the reports that they had done, I think, in the summer of 2020. Do you know whether there was such a review conducted?
So what happened with the task force report was it sort of morphed into the winter plan, and the two things were published alongside each other. And the winter plan talks a lot about all the sort of resources that there
I'm going to show it on screen in a moment. So with that in mind, should we call up, please, INQ 40588216 _ 3738. And I've just pulled out the support part of the winter plan. And we can see there national support and indeed actions for local authorities. But I suppose really the question is this is a plan that came out, I think, in September of 2020 in preparation for the winter of 2020 to 2021. Was there any support put in place for the workforce prior to the publication of the winter plan?
So I think quite a lot of these things had already been put in place, and I think some of them are referred to, but I couldn't tell you off the top of my head which they are, in the April plan published on the 15th of April, and then the one in May, the care home support package, published in, so on the 15th.
Well, perhaps I can help you, Ms Dyson, because certainly if we look at some of the bullet points, there is an offer to the workforce is brought together in the Care Workforce app. That is something that was launched in May of 2020, according to your statement. And there was certainly some guidance issued on health and wellbeing in May as well. So, do you know, for example, what specific work the department did to try and support the wellbeing of the workforce aside from the winter plan?
I think this was principally it. I mean, the next page of this talks about the responsibilities of providers, and clearly the adult social care workforce is employed by, sort of 18,000 providers. So it's very, very different from a public sector sort of national workforce like the NHS. And first and foremost, it's for providers to look after the well-being of their staff.
You alight on there perhaps a distinction between the NHS workforce and the adult social care workforce, but clearly the NHS England, for example, launched a dedicated mental health hotline for NHS staff. Is that something that the department could have chosen to do for the adult social care workforce, notwithstanding that it's for providers to help, but give the overarching banner of support to adult social care?
I suppose it could have chosen to do that. There was always an issue about how you reach all the adult social care workforce. There is no register of the workforce, so there are all sorts of things you can provide, but will they be taken up by, as you said at the outset, so 1.2 million people who are employed by 18,000 providers?
We are aware that Northern Ireland, Scotland and Wales have a mandatory registration for both, I think, residential and domiciliary care workers. Not the position in England, as we understand it. Do you think a register of the care workers would assist in the event of a future pandemic, and if so, in what ways?
It would definitely assist in the event of a future pandemic, because there were times when we thought about how can we get to the workforce, and we had no route to get to the workforce other than through providers, which is obviously an indirect route to the workforce.
Yeah. Given the size of the workforce in England, which is on any view much larger than in the devolved nations, how feasible is it for there to be a mandatory registration requirement?
I mean, it's feasible, but there are plenty of people who think it's not a good idea. So there are mixed views on this, but it is feasible.
Do you, on behalf of the department, do you have any views as to who should keep such a register and maintain a register? I
mean, if we were to have such a register, And this goes to the question of, I mean, you could have sort of skills for care, that they have the adult social care workforce data, but I suppose if you were moving into a world of workforce professionalisation along these lines, I mean, maybe it's not the right thing to do to have it sort of held at such arm's length from the department. Skills for Care is an independent charity, and you could set it up within the department. All these things would be feasible. But as I say, there are very mixed views on whether this is a good idea.
What about the views that...
I'm sorry, Ms Carey, can I just interrupt?
Yes.
What are the opposing views to a register, Mr Dyson? I don't know if Ms Carey was going to cover it. I may have stopped her in her tracks.
Not at all.
I honestly, I can't remember the detail of this. I remember Matt Hancock was very keen to do this. And I also think we consulted on it in late 2021 as part of some reform work. But I think there are stakeholders who think that this is not a good idea. They think that it might put people off. But I think I'm afraid I can't remember the detail of why they're against it.
Thank you.
One aspect of the pandemic was undoubtedly emerging evidence that showed that there was a disproportionate impact of COVID on black and minority ethnic members of staff. And can I ask you a little bit about that, please? Because I think at your paragraph 449, you make reference to the risk reduction framework. I'll just let you turn it up, Ms Dyson, as I do as well. But the department developed what was called the Adult Social Care Risk Reduction Framework to be used in all social care settings or social care interventions. It was to provide guidance for employers on how they should support workers who were more vulnerable to infection or adverse outcomes, including the risks by ethnicity. And that framework came out on the 19th of June 2020. Can we have a look, please, at INQ 109673? And this is an extract from a report done by the Adult Social Care Support Task Force BAME Communities Advisory Group. It was an advisory group that worked between 31st of July and the 14th of August 2020, so just a 2-week period. And they received 142 responses from the social care workforce. And we can see there that confidence in support, the quantitative section of the group's work showed risk assessments were often a successful measure for BAME staff to feel more secure. Higher level of confidence around support coming from employers than the government or official guidance, and the majority of respondents had been risk assessed regarding ethnicity. And you can see there, perhaps we just zoom out again. Have you had a risk assessment based around your ethnicity? Actually, 90 of the 142 respondents had, and 52 hadn't. But if we just look to the bottom of that page, clearly over that 2-week period, the respondees were asked for their awareness and take-up of that social care risk reduction framework, and it was much lower. And if we go over the page, please. When asked the question, are you aware of the framework, 88 people said no, so almost 2/3 of the respondents. Have you used it? Even worse figures, 109 of the respondents had not. Do you know whether the department was aware of, albeit a small study, but nonetheless an important study that showed perhaps the risk reduction framework wasn't being utilised as no doubt as much as the department would like?
I think the important, so this is part of David Pearson's overall task force. I think the important thing here was, were people having the conversations? I think it mattered less whether they were having the conversations because they knew about the risk reduction framework than were they having the conversations in the first place. Because the risk reduction framework was all about supporting those conversations. It was saying you should have a conversation, this is how you do it, it's a very sensitive issue, these are the sorts of things you should talk about, and then this is how you can mitigate. If those conversations were happening without reference to the risk reduction framework, then I don't think that that's a that's a problem. And in fact, if we put out a risk reduction framework on the 19th of June, bearing in mind how difficult it is to get things sort of across such a large sector, I'm actually quite surprised that, 38% of people were aware of the adult social care risk reduction framework.
I follow your argument, which is as long as the risk assessment's been doing, whether it's the risk assessment framework that provokes it, it doesn't matter. It's important that the risk assessment is undertaken. But nonetheless, this was an area where the department were concerned about the disproportionate impact, and arguably the framework that they put out isn't certainly getting the airtime or the publicity that perhaps the department wanted. And you could have had more risk assessments potentially if the framework had been better publicised. There is that argument. Do you see that, Ms Dyson?
Potentially, I mean, we would have used, I don't know if we did in this case, but we would have used Skills for Care as a way of reaching the workforce.
And is the risk reduction framework still in place now, or is that a pandemic specific?
Not that I'm aware of. Could I just mention one other thing that was happening at the same time as this on the question of sort of risk around ethnicity, which is the decision that was taken on the 26th of June to prioritise the adult social care workforce, the care home workforce for regular asymptomatic testing, to prioritise them ahead of the NHS by several months. And that was taken partly because of the risks in care homes to residents, but also because of the risks to the workforce, and the evidence that went into that meeting when those decisions were taken explicitly talked about the fact that 21% of the adult social care workforce was from an ethnic minority background, rising to 60% in London, and other risk factors such as living in housing of multiple occupation, being on 0 hours contracts, etc. So we were doing other things alongside at the same time in June 2020.
No, and thank you for adding that context, but if the department is going to go to the trouble to put out a risk reduction framework, but then it doesn't seem to have landed with the workforce, it's not necessarily the best advert for trying to support the workforce, particularly those who are disproportionately affected, to understand that they are being thought of, looked after, and work is being specifically done for them. Do you think perhaps there's a communications issue surrounding things like the risk reduction framework? It wasn't publicised enough.
I mean, possibly, but as we discussed before, it's really hard to reach the whole of the workforce because we don't have a list of who they all are. And I do think the fact that this is, I think you said August, so it's potentially sort of 6-8 weeks on, things always take a while to get through. So it would have been interesting to see, if you'd done a similar survey a few months later, would the numbers have improved?
Well, that's what I was going to ask you. In addition to the prioritisation of asymptomatic testing and things like the framework, are you able to point to any other measures that the department took to try and address the disproportionate impact of COVID-19 on the adult social care workforce?
I mean, the vaccine, clearly, which was prioritised for the adult social people working in care homes, they were in priority number 1 alongside residents because of the risks both to residents and to them within the care home environment.
I think, Ms Dyson, though, you're aware that certainly, particularly within some black and minority ethnic communities, there is lower take-up of the vaccine for a number of different reasons. Aside from the vaccine, I just wonder whether there was perhaps not enough attention given to trying to promote the department's concerns to protect black and minority ethnic workforce members.
I mean, I'm not aware of other things that we did. There was a lot of work done, but particularly if we come back to the vaccine, the NHS England did a huge amount of work to with ethnic minority communities to encourage them to take up the vaccine, which was for their protection.
And whilst we're on this topic, can I ask please to look at INQ 543049. This is an extract from a statement by Skills for Care. I'll just wait for it to come on screen. And if it doesn't, I can read it out to you, Ms Dyson. But the social care workforce race equality standard collects data from local authorities on 9 race equality indicators. And I think you're aware that Skills for Care have recommended that the Department of Health, along with the Ministry of Housing, Communities and Local Government and DfE, should mandate and fund implementation of that workforce race equality standard into all its work. Can you help with any Department of Health comment on the Skills for Care recommendation?
So the department funded a pilot of 18. So this is for local authorities. The department funded the first 18 local authorities getting this standard. The department also funded the data tool to support the rollout of the race equality standard. Since then, as I understand it, Skills for Care have been rolling it out themselves without funding from central government. I believe they've got to around 73 local authorities, so they seem to be doing a good job in getting this out to local government, building on the pilot of the first 18 that was funded by the Department of Health and Social Care.
And can you help us, in what way would the Department of Health have been assisted if perhaps this had been rolled out sooner or more local authorities were complying with it in the pandemic? I mean, obviously data is a good thing, but is there any specific thing you can point to and say, well, that would be really beneficial had we had the equality standard collected data?
So this was about local authorities. I think it is about local authorities' own workforces as opposed to the care workforce. So it's about people, social workers, etc. I'm sure that would have been useful given the concerns about race equality, but it's not obvious to me precisely what it would been. I mean, I think that's probably a question for local government as to precisely what it would have been useful for.
Now, I turn to a different topic, and that's of visiting restrictions, please. The inquiry is aware, essentially, of the competing arguments here, of the need for protection of those who are in care homes, but equally the real harm that is done by the isolation and lack of familial contact that that restriction brings. I'm not going to take you through all the various iterations of the visiting guidance, but at your paragraph 289, you make reference to the SAGE Social Care Working Group consensus, and there was essentially not that much evidence, if any, to deal with the extent to which visitors transmitted the virus into care homes. They said evidence was weaker on the risk of introduction and transmission of COVID-19 infection from visitors. Further work through the commissioning of new studies was needed. Was or is any work being done by Department of Health to try and work out the extent to which visitors bring in infections into care homes?
I think the point here was that there wasn't the evidence that we would have ideally had, but on the other hand, it was very clear that all footfall, if you like, into a care home brought risk with it. So anyone coming into a care home for whatever purpose, that was a risk. So in answer to your question, I'm not aware that we're doing any extra work in this space.
It's just that a number of the bereaved group members in particular say, well, if the evidence emerges that we're not a vector of transmission or a significant vector of transmission, it makes the argument for imposing visiting restrictions less. And I suspect you can see that point, but hence why they are keen to know whether there is an evidential basis for the restrictions in terms of the data showing that they bring in X proportion of infection.
I mean, I think this is a question principally for Public Health England, but every time we made changes to the visiting restrictions, we worked hand in glove with Jenny Harries, with Public Health England. So they were very much part of our decision making in terms of how to balance these risks.
I follow that PHE, or UXA as it now is, has a role in it, but is there anything preventing the department for asking such research to be done so that we understand the extent to which visitors bring in infections?
Not that I can think of.
Whilst we're on visiting restrictions, in your first statement you make reference to the changes brought about by Regulation 9A, which came into being, I think, in 2024, which aims to make sure that people staying in a care home or indeed a hospital receive visits from people they want to see. And can you help us, please, with what was the rationale behind amending the regulations to bring in or codify effectively a right to receive visitors in care homes and hospitals?
It was the experience of the pandemic. So at every point in the pandemic, we were wrestling with trying to square the circle, as to balance things. I mean, it is to note that when Omicron came, and I don't know if the inquiry has heard evidence on this, but at the beginning, when we first got notified about Omicron, which was the end of November 2021, we were incredibly fearful because we knew it was much more infectious than what had gone before. And at that point, we didn't know whether it was more lethal. And so we were fearful we were going back to the position, more equally lethal, we were fearful we were going back to the position of March 2020. But against that backdrop, we decided to not to close care homes to visiting. We brought in restrictions again, but we kept the essential caregiver, learning from the experience of what had gone before. The regulation that we brought in that you mentioned was really to codify that experience and make sure that it would only be in the most exceptional circumstances that care homes would be closed to visiting.
Well, that's what I wanted to ask you about, because there is that caveat that clearly if exceptional circumstances apply, then the right to have a visitor falls away. But wouldn't a pandemic effectively be the exceptional circumstance? Wouldn't we be back in the position that we were in March, April, May of 2020?
I mean, the guidance that CQC has given underneath that provision makes it clear that it really is, if it really, really can't, there is no way of doing this safely. But we can't close the door to, it is possible that you get another pandemic where in order to keep people safe, you do have to sort of close visiting down again. I mean, I very much hope we don't end up in that place.
I think you say in your statement it's the CQC have a role to play in ensuring that visitors are allowed. And I think there's a correction to make, is there not, to your paragraph 52 in your statement A, where it should be a reference to 2023 amendment regulations, not to the Health and Social Care Act of 2022. All right, well, we'll deal with the formalities, but thank you for that. Can I ask you, please, about do not attempt cardiopulmonary resuscitation notices, please? It's your paragraph 615, Ms Dyson, if it helps you, onwards. And one of the things that you say there, I think at paragraph 613, is you say that the department did not receive evidence of, let me just turn up the paragraph myself, evidence of inappropriate and blanket use of DNA CPRs. What do you mean when you say the department didn't receive evidence of it? Because the department was clearly aware of concerns, and I just want there to be no misunderstanding about what the department knew or had been told.
I mean, there were many examples of anecdotal examples of this, and indeed the CQC review that was done, I think October 2021, said that was the case. I think that sentence maybe simply means we didn't receive, sort of comprehensive sort of analysis on this, but absolutely we were hearing about it.
I didn't want there to be any misunderstanding about the fact that this was raised as an issue with the department. And could we have a look on screen, in fact, at INQ 000565710_2? This is an email sent to the department forgive me, the date has disappeared off it, but it was sent to the department, and in the middle of, thank you, 11th of April, thank you very much. There is reference, can you see at the point 2? They're commenting on a piece of evidence, but in the middle of that paragraph, you see there is a perception that people receiving services in a care home and with COVID-19 symptoms are automatically palliative. Not every GP practice is taking this approach, but many are, and the press are not helping. This is similar to the blanket DNAR to which you reference elsewhere. We do not have any volume of statistics yet, but some people in care homes showing symptoms do survive, and I think we should be acknowledging this fact. And they talk about a standard reporting procedure I mentioned below also has a role in dispelling this, or statements that those requiring NHS hospital treatment will continue to receive it. Are you able, anything you're able to say in this area will go some way towards services not feeling totally isolated and cut off, and minimising the fear that everybody in a care home will die? Now, a number of issues in that section there, please. But is this an example, or perhaps of some of the anecdotal evidence to which you just referred a moment ago, with emails being sent into
Yes.
the department and the like? Right. From the department's perspective, was there ever a policy that promoted or enabled there to be a blanket DNA CPR policy?
Absolutely not.
Or any policy that elided do not attempt cardiopulmonary resuscitation with the fact that other treatment must still be continued?
No. The department, as soon as it heard about this, the department, through multiple routes, wrote out to the sector. I mean, I can go through the list if it's helpful, but through the NHS, through adult social care routes, through the chief social worker routes, through the chief nurse, everything it could do to say this is completely wrong, do not do it.
We know that in the autumn of 2020, the department commissioned the CQC to do a DNA CPR report. There was an interim report and a final report with which the chair is very familiar. And in due course, there was I think a ministerial group set up to develop universal principles for advanced care planning. Could we just have a look at that, please? INQ 0005887 page 168 to 169. It's probably easier just to put the paragraph up on screen from your statement. So one of the key outputs of the group was the joint publication of a universal principles for advanced care planning, published in March 2022, as to what good looks like. And we can see there 6 high-level principles. Thank you. Person is central to developing and agreeing the advanced care plan. Personalised conversations. Person agrees the outcomes of their advanced care planning conversation, and so on. And without wishing to disparage the work of the universal principles, is there any other work being done, though, to provide more ground-level guidance to ensure that there isn't blanket or inappropriate DNA CPR policies being written or being imposed on people in care homes and the care sector? What's sort of at the level under this, if I can put it like that?
This then became part of the single assessment framework, which the Care Quality Commission uses. And that, if you like, is the best way of getting to all the care providers, because that's the basis on which they are inspected.
Can you help us now with where DNA CPR records are kept for the adult social care sector? Because we've often heard about perhaps there being a GP record, maybe a hospital record, maybe a care home record, and not necessarily the 3 records aligning. Do you know now if there is one central repository for DNA CPR records as far as the adult social care sector is concerned?
So I've been trying to get to the bottom of this. There is a digital care record for care providers. I understand any DNA CPRs are not kept there because they have to be signed off by the GP, so they will be held somewhere within a GP record, but I'm not sure what, in terms of a sort of central repository, I'm not sure what that would be, but we can continue to try and find out and let the inquiry know when we have.
One of the concerns of the bereaved groups is that the CQC report that was commissioned was perhaps commissioned too late in the pandemic, and there have been these concerns that had been growing from a much earlier stage in the autumn of 2020. Can you help at all about why the decision was taken in the autumn to commission the CQC report?
I don't know why it was in the autumn, but I think the really important point is how much action happened during April. We could not have done more, I think, to communicate out through every channel that we have across the health and care sector to say that this was inappropriate. And in fact, that was noted in the CQC review that said there was evidence of unacceptable DNA CPRs being used at the start of the pandemic, but there was a quick response from multiple agencies to highlight the issue and deal with it.
Given that there was no departmental directive saying this was acceptable or permissible, did the department do any work to try and understand why, given this problem was still happening, even though no one told that GPs to do it or care homes to do it, to try and understand what generated?
Well, I think that was the CQC review. That was the mechanism to try and understand that.
Okay. Can I come on to deal with the issue of data, please? And this is mainly covered in your Part D statement, Ms Dyson. And you say at the outset of that statement that Department of Health was not operationally responsible for adult social care data collections. But you did receive annual returns from NHS Digital. We know that the CQC included data in their annual report. But is this the position that going into the pandemic, there was no real-time data available to the department?
Yes.
Right. Now, there were some changes made during the pandemic, and I'd like to ask you about some of those, please. And in particular, you say there was changes made to test and trace data, deaths of care home residents data, and reporting via the capacity tracker. Perhaps my packaging up or yours, but I'd like to look at those three areas with you, please. Data from test and trace, you say was useful to show prevalence and outbreaks. Can you help with, and it's your paragraph 16 and 17 in Part D. When did the test and trace data become available to the department? Because we know test and trace was launched on the 28th of May, and we know it was reported in SIPREP data from the 16th of October, but it doesn't mean the data wasn't available to the department before then. Can you help?
So the test and trace data, I mean, it became most meaningful once you had regular testing. So that rolled out from July, but probably didn't become to get into its full rhythm, I would guess, until about September. We then had the dashboard that was built, the Palantir dashboard, that came on stream about that point in time, so end of September, beginning of October, and that was where the test and trace data was reported and reported daily.
That brings us on to the dashboard. I think you said in your statement it was rolled out from the 1st of October 2020. It was interactive, and local authorities had access to the dashboard, and indeed ministers used it at meetings and various other groups. Can you help me with this? Was the dashboard in any way developed in secret or without DHSE's knowledge?
No. There were many emails. You can see all the different people who were involved, including sort of analysts from my team, across with Palantir. I think the NHS held the contract maybe at that point with Palantir. Many people were involved in developing the dashboard.
Right. Was there any ever orders that you're aware of not to share the dashboard with either ministers or any other group that wanted to see the dashboard data?
No, absolutely not.
Can we have a look, please, at the actual data itself? Thank you very much. It's INQ 512951. And I wonder if I could go to page 23, which I think may be a couple of slides on. Thank you. This is an extract from the 5th of January of 2021. And it shows here the regions across England and a summary of the positive cases, both of staff and residents. Is this in care homes, Ms Dyson?
Yes.
And we can see there that as of January 2021, there's significant increases in London, the East and the South East compared with the previous 7 days. And so it's a useful tool to show you increase in infection rates or decrease depending on the position. Obviously that regional overview was helpful, but help us with the dashboard. How from there did one go to working out perhaps which local authority had a problem or which care home in particular had a problem? How did it sort of trickle down?
So this is the dashboard that many of us looked at every day, and it was vital. It gave us this rolling 7-day data. So as you say, you could absolutely compare, see what was going on at national level, then at regional level. Then you could click through and you could get to all the 150, I think it was then 152 local authorities. And from there, you could click down into all the care homes that were in that local authority. And then you could see what was going on in that care home, and you could see that care home's capacity tracker data. So, for example, in a care home where there was an outbreak, you could have a look and see, well, what are they doing on staff movement? What are they doing on paying sick pay?
So you could actually go down to sort of care home level and know what their outbreaks were, how many staff absences there were. I think, did it cover PPE and whether they had sufficient supplies? You mentioned the capacity tracker. Is that a different data set, or was it just sort of sat under the regional and indeed national overview?
So what the dashboard did was bring all these different data sets together. So what we're looking at here is test and trace data, but the brilliant thing about the dashboard was it combined test and trace data and capacity tracker in a way that was very accessible for us as policymakers in the department. And we could then, once we saw what was going on, we had a regional, or we were building our regional assurance team, and they could get on the phone to the relevant local authority or care home to say, to just ask some questions about what was going on.
Is the dashboard still in use?
No.
No.
But capacity tracker is.
Right, I'll come on to that. Is there the capability, nonetheless, in the department to get the dashboard back up and running again in the event that we have a future pandemic?
I'm sure we could do that, yes.
Now, the tracker, can you... I think that was something that was adapted for use during the pandemic. It was voluntary, as I think you said earlier. But clearly, one of the things during the pandemic to try and encourage provision of data was to make access to funds, not just the Infection Control Fund, linked to whether returns are made by the capacity tracker. Help us with the position with the tracker today. Would it be useful still if there were a future pandemic now? Because clearly you might want to look at bed capacity outside of pandemic times, but what does the department say is its benefit in the event that we had a pandemic later this year?
I mean, we still use it for all sorts of purposes. Bed occupancy, we look at staff absences. So there are all sorts of purposes it's currently used for. It's very easy for us to add extra fields if we need to. I mean, there is obviously a process to be gone through because we're conscious of imposing burdens on providers, and it's important there's proper governance around it. But it would, in principle, be easy to add in extra data collections into capacity tracker. And
I think it may be something you said earlier, forgive me if I'm repeating myself, but is it now mandatory to...
Yes.
Thank you. All right. A couple of different topics, please, perhaps before we wrap up. In your Part E, which is your lessons learned part of the statement, you make reference to the Chief Medical Officer's technical report, which refers to research and innovation to increase care home resilience. Are you able to help with any work that is being undertaken by the department now to conduct research or have the capability of standing up research in the event of a future pandemic?
So there may well be things going on in UXA. The thing that I'm aware of is that the Vivaldi study is still going, albeit it's no longer looking at COVID, but it is looking at care homes from sort of other perspectives. So I think that is very useful research for the future.
In relation to Vivaldi, can I just ask you a few questions, please? I think was there a budget set for the project as far as the department is aware?
So we've been trying to get to the bottom of exactly what happened with Vivaldi. We've been digging around in lots of emails. So from the emails that I have seen to date, I've seen a lot of emails going on in May with people trying to get a budget for Vivaldi, involving finance people, involving commercial people. This was a procurement issue. I haven't seen where that actually got to. but definitely people were doing everything that I would expect them to be doing to get a budget for Vivaldi.
Was there, or do you know whether there was anyone in the Department of Health at that time that didn't want the Vivaldi project to get up and running and report on its findings?
I mean, there's nothing that I've seen in all these emails that would suggest that that's the case.
Were you aware from your researches whether the department refused to share data with the Vivaldi project?
Again, nothing I've seen in these emails.
Do you know whether Minister Whately was briefed in private about Vivaldi?
Not that I'm aware of.
The inquiry has seen some evidence to suggest that in summer of 2020 there were meetings in the Department of Health where people were making comments like, come the inquiry, or we better cover our backs, to put it ineloquently. Have you seen any paperwork that suggests that comments like that were being made?
No.
By the time you joined the department in September, were comments like that being made about the need to cover themselves?
I can't recall anyone making that sort of comment.
From your researches, was there any suggestion that the department did not want to uncover perhaps the scale of infections in care homes?
Not at all. And it is worth adding another point about Vivaldi. Vivaldi was a really important study, but what Vivaldi uncovered, we already knew, albeit this was a more robust study. So, for example, Vivaldi talks about preventing staff movement. We already knew that. We had already taken action in May to stop staff movement. Vivaldi, the importance of testing, we already knew about that. So Vivaldi is important, but it's not the only study that matters. And in fact, most of the action all the action that was needed, that Vivaldi points to, was already underway, albeit Vivaldi was a sort of massively and very robust study.
And another topic, please, is that of Care Act easements. Clearly, there were a number of conditions placed on local authorities when they adopted an easement or a modification to the assessments that were carried out. I think the department is aware of concern from user groups and carer groups about potentially unmet needs being prevalent, or lower well-being, changes being made at the last minute to assessments and the like. You have set out in your statement that by the 18th of May 2020, there were 6 local authorities, all in the Midlands, that were using easements, and 2 other local authorities that had used them but had stopped using them. On any view, potentially quite a low number of local authorities in the scheme of things, and certainly no easements have been used since June 2020. There is a concern that perhaps they were being used, but that local authorities were not notifying the Department of Health that they were being used. Did you in the department get any sense of whether that was or might have been happening?
I don't think that was the case. I think the issue is whether, because what was happening was people were using Care Act flexibilities. And in fact, when Omicron came and we considered whether to turn Care Act easements back on, what local authorities said to us was, no, we don't need it because we have the flexibility within the Care Act. So I think the point, there's an important study by a Manchester University study, I think.
Yes.
And the concern there is, well, actually, is there too much flexibility in the Care Act?
Can we have a look at that?
Yeah.
Because it might help those following. Can we have up on screen, please, perhaps your statement ending 737 at page 159. It might just take a moment to bring it up because we're flitting between statements. It's INQ 587 737 159. And at the top of the page, there's reference to the University of Manchester study in November 2020. The project investigated the impacts of Care Act easements on older carers of people living with dementia at home to make recommendations about the operation of this legislation. And there's the report one of the main findings, that carers and the family members they were supporting, quote, experienced significant changes from their usual care and support, which in many cases resulted in lower well-being and unmet need. And it goes on, I think, to set out the point that you were just referring to, Ms Dyson, that although the experiences were similar across the local authority areas in this study, easements were differentially implemented, soon revoked, and not enforced for any local authority beyond July 2020. There appears to have been little consequence, whether political, legal or regulatory, for local authorities that did not invoke easements. However, for local authorities that did, there was considerable pressure from lawyers, NGOs, lobby groups and adverse media attention. Was the department aware that local authorities that did invoke easements were coming under some criticism?
Yes.
And what was the department's view about it from that angle in the first instance?
The chief social workers went out to those local authorities and conducted extensive interviews to understand how they were using the Care Act easements and make sure that it was all in accordance with the guidance, which they concluded that it was. I sort of understand the point that says it feels a bit unfair that these local authorities that use the Care Act easements in exactly the right way were coming under pressure, but other local authorities who did similar things but without going through that process didn't come under. So I understand the point.
To go back to from the other angle, though, and perhaps the significant changes being reported by carers and their family members, which resulted in lower well-being and unmet need, can you help with what safeguards, if any, were written into this to try and prevent there being such dramatic changes to people's care needs?
I do think some of this will have been about lockdown more generally. So, for example, I know it was really difficult, and I should say the University of Manchester report makes very, very difficult reading. But some of the problems that it's alluding to were caused by lockdown. So, for example, day centres closing, and indeed I understand some families decided that they didn't want care, because they didn't want a home carer coming into their home because they were concerned about the risk of COVID. What we did generally was there was an ethical framework, which in fact the Permanent Secretary commissioned in February, which was published on the 19th of March. It was always very important that all decisions of this kind, whether under Care Act easements or not, were taken being cognizant of that ethical framework. But the broader points that are being made here, which is about how do you have oversight of what's going on in local authorities in terms of the sort of flexibilities that there are under the Care Act. We've now legislated so that CQC inspects local authorities, the way in which they exercise the Care Act. So they will be looking at these types of issues, either within a pandemic, let's hope not, or in normal times as well.
That perhaps brings me on to my final point, and levers or the lack thereof. We've looked at the financial incentives that perhaps can be levied to try and ensure data returns are being met. You've spoken there of, I think, changes to ensure that the CQC inspects to ensure that Care Act responsibilities are being applied. But from the department's perspective, is there any recommendation that the department has got as to how to ensure it has the levers it needs, aside from those discrete areas that we've spoken about already this afternoon?
I think this goes to the Baroness Casey review, because there are big questions here about whether adult social care is set up in the right way.
I understand that, but that review may be many months, if not years away. If we had a pandemic more immediately than that, do you have any recommendations or suggestions for how the government could gain the levers it might need to be able to support the care sector and indeed impose things on the care sector?
I think we're in a much, much better place than we were in 2020 through the legislation we've already talked about, through data, through CQC inspections, through the visiting regulations. And then there's one we haven't talked about, which is the power that government now has but hasn't yet used to be able to give money direct to providers. So all the money that went to providers during the COVID pandemic had to go through local authorities, instructing them to pass it on. We now have the power to fund providers directly.
Ms Dyson, thank you very much. My lady, that's all the questions that I asked, but there are some core participant questions.
There are. Thank you, Ms Carey. Ms Dyson, just a few more questions for you, but I promise you are going to finish by the time we finish this evening. Ms Morris. Should be just your right.
Thank you. Good afternoon, Ms Dyson. I ask questions on behalf of the COVID bereaved Families for Justice UK. My first topic is returning back to the issue of COVID positive staff within care homes. Now, Ms Carey, King's Counsel, has touched on that with you already. I wanted to expand a little bit in terms of the detail, please, and the scale and some of the underlying issues. Already mentioned your note or draft note to the Minister from January 2021, in which you highlighted 6 cases the department was aware about. And I think following that draft note, the number of reports that the inquiry has evidence of increased by 50 in February and 94 in April. You said you thought it was about 25. I just wanted to draw your attention to that. So by 13th of April 2021, there was 94 reports within the department's knowledge. I wanted to ask you if you could help with whether there were cases of staff continuing to work in both residential and in community settings. Was it in both or just in one?
I don't recall, but I mean, all the cases that were brought to my attention were in care homes. But as you say, now that if there were 94, then yeah, I don't know where all of those were.
Okay. In your draft note back in January to the Minister, you say that it appears that in some cases, the action has been signed off at a local level on the grounds that there is a risk to safe staffing levels without COVID positive staff continuing to work. So I wanted to ask you, do you agree that the prevalence of COVID positive staff continuing to work during the pandemic was illustrative of the failure of the UK government to grip the workforce issues and shortages that had been known before the onset of the pandemic?
I mean, we're talking about 94 staff out of 1.2 million, so I do think we need to think about it and get the sort of perspective on that. I mean, as we have discussed, there were problems in the workforce. There were problems particularly at this time, but equally there were times during the pandemic when things as regards the workforce were relatively stable. I think we saw an email on that, making that point just before the break. So I think this was a particular issue. I should just add that draft note became an actual note about 2 hours later and went to the Secretary of State, and then there was a note to the Prime Minister on it over that weekend.
Okay, thank you. You've touched on some of the money delivered through the Infection Control Fund, but given the reports that were received by the department, do you accept that money had proven insufficient to tackle the problem of preventing COVID positive staff coming into work?
Well, that's why we're doing the Workforce Capacity Fund that actually had already been announced by the time of this note. So that had been announced a couple of weeks earlier. This was the end of January. I think the Workforce Capacity Fund of 120 million had been announced in mid-January.
My next topic, the March 2020 hospital discharge policy. And I wanted to ask you a little bit more about that, please. So there was a national steering group meeting on the 11th of March of 2020. Ros Roughton, the then Director of Adult Social Care, emailed NHSE with her concerns that, quote, DHSC was lacking the ability to tell local authorities what she referred to as the, quote, scary narrative on what the pressure will be like in the acute sector so that they can really understand why the NHS may need to act the way that it does. And after the hospital discharge requirements had been issued on the 19th of March, PHE officials noted that NHSE had, quote, major concerns with the guidance for infection prevention and control in care homes and would lead the sector to being, quote, too risk adverse, creating what they described as being blocks in the system. I wanted your help, please, with, first of all, why weren't DHSC officials able to tell local authorities this scary narrative on what pressure was anticipated to be just days from that meeting?
I hadn't seen that email. I don't know about that. But I mean, they clearly, as part of the narrative around the hospital discharge, it was being made. And I remember, I mean, I think you said that the Ros Roughton email was did you say the 13th of March? Or
11th of March.
11th of
it's
March.
after the 11th of March.
Yeah, so things change a lot between the 11th of March and the 19th of March. So I'm sure that by the time of the hospital discharge, guidance on the 19th of March, I'm sure that there were conversations happening about the need for it. We needed local authorities to be helping with the hospital discharge policy.
As you say, is it fair to say that the DHSC and the NHSE needed care homes to be willing to accept untested patients from hospital if that policy was in fact going to be effective?
Yes.
So if there's an unwillingness or lacking the ability to deliver this scary narrative, was the ASC sector deliberately kept in the dark so that when the time came, care home managers would not be too risk adverse in accepting urgent hospital discharges?
I think we're missing between the 11th of March and the sort of 19th of March. I just don't know. I wasn't there at the time. I don't know what happened in that period. But clearly we were getting closer and closer. Lockdown was on the 23rd of March. Things changed very rapidly in that period. I'm sure that we were communicating with the sector about what was going on. I mean, there was more guidance issued on the 13th of March. Things were moving extremely rapidly. So I don't think we should read into an email on the 11th of March to say that there was no communication with the sector after that.
You've recognised in your evidence already this afternoon that there was later the development of designated settings. On the 20th of April 2020, PHE suggested that consideration be given to the creation of what they called hot care homes as a place to cohort and manage COVID-19 positive cases that didn't require treatment in hospital. What consideration, if any, was given to that as an option before the March 2020 hospital discharge policy was put into place?
Again, I haven't seen that. What was the date of that? The hot.
So 20th of April, this is when the hot care homes came as a suggestion. But why wasn't that considered before March 2020?
I mean, the issue about hospital discharge is that we didn't know about, we didn't have the testing to know who was COVID positive. It just didn't exist at the time. And we didn't know about asymptomatic transmission. By the 20th of April, we did know about all of those things, and the guidance had changed on the 15th of April to say that you must isolate people when they go into care, when they come from hospital into care homes. So I think it was just a case of what we didn't know at the point of the discharge guidance, but we did know by the 20th of April.
My third topic, and my final topic, is around PPE and guidance for unpaid carers. So in the 13th of March 2020 guidance for home care, the authors noted that the provision of care and support within people's home is a high priority service, and in that most care and support cannot be deferred to another day without putting individuals at risk of harm, and therefore it's vital that these services are prioritised with this guidance and support. And this particular guidance advised the use of PPE, including face masks for those performing domiciliary care, when in up close and personal contact with those they were caring for. But in relation to face masks, by contrast, on the 8th of April, guidance to unpaid carers said we do not recommend use of face masks as an effective means of preventing the spread of infection unless you're told by a healthcare professional. As far as DHSC was concerned, was the care and support provided by an unpaid carer to a person in their home a high priority service in the same way as a domiciliary carer?
It was absolutely, the value that we put on unpaid carers was just huge. They did an amazing job during the pandemic in really, really difficult circumstances. We've already talked about the advice that Public Health England gave us about why PPE for unpaid carers at this point in time was not appropriate. Obviously, things changed later in the year.
Can you see why that distinction in guidance seemed illogical to many of the bereaved families in the UK and Northern Ireland, amongst many of those are unpaid carers? Can you see the?
I think it's important probably to distinguish between the extra resident unpaid carers and those living in the same household. So PPE was never recommended for people living in the same household, except where the COVID was actually in the household. Where we moved to was in treating the extra resident carers in the same way as domiciliary carers, but later in the year.
Thank you very much. My lady, my remaining questions have been covered by Miss Carey. Thank you. Thank you very much.
Very grateful, Ms. Morris. Thank you very much. It's now Ms. Jones. If you look across the hearing room, Ms. Dyson, you might see her.
My lady, Miss Carey actually covered the topic that I was going to ask about, so I've got no further questions for Miss Dyson.
I'm very grateful, Ms Jones, thank you. Ms Beattie, who's probably behind her.
Thank you, my lady. Ms Dyson, I ask questions on behalf of disabled people's organisations, and the questions concern Care Act easements, which you have covered in your statements and which continued to be in force after you came into post. The Minister for Social Care, Helen Whately, was provided with a submission on the 19th of May 2020 on the impact of Care Act easements. And that submission said that chief social workers had spoken to or corresponded with principal social workers from the 7 local authorities then operating easements. It might have been 6 at that point, but there had been a total of 7. And that was out of a total of 153 local authorities in England. Is that right?
Yes.
The chief social workers had not contacted or reviewed what was happening in the other 146 local authorities, but only the 7 that had formally notified their use of easements. That's correct, isn't it?
Yep.
The submission, the same submission of the 19th of May, had said in terms, and for the record, this is at page 3, paragraph 6 of that submission, there is a gap in our knowledge concerning local authorities who are not operating under easements, but whose actions mean they should be. In order to fill that knowledge gap, the department needed to know about local authorities that had not formally declared easements, but who were taking actions such as reducing the care provided to people with care plans, leaving them with unmet needs, didn't it?
As far as I know, people were using the existing flexibilities in the Care Act. So I think you can say, well, the Care Act, you could make the contention that the Care Act is too flexible. And there have been, people have talked about concerns about unmet need for many years. But I don't think you can say that well, I don't have the evidence to say that they ought to have been using Care Act easements. I just don't know.
Well, is that precisely the thing that the department needed to look into, whether the local authorities were applying flexibilities or really were in the territory of easements?
Yeah, I think it's just very difficult to get, you've got a whole country, we do have to, local authorities have the statutory duties here. They know their populations really well. They are real experts in adult social care. Although I had chief social workers, I had 2 job-sharing chief social workers, the idea that they could get across the whole country and do what they were doing in those sort of 7 local authorities across the whole country, I don't think that they could. As I said before, I think we are now in a different place, given that we have the CQC inspection powers, which could be used for exactly this type of thing, and CQC have the expert, they have employed the experts to do, in the right numbers, to do this work.
The next submission to the Minister on the 25th of June 2020 stated that monitoring of the overall system should remain light touch, since chief social workers have good oversight of the only local authority still operating under easements. So that light touch monitoring would again, as I think you're accepting, still not tell you anything about the local authorities that had not formally notified the easements, would it?
No, I mean, that's right. But as I say, I think we're at risk of sort of almost cutting out the expertise of local authorities here, who both have the expertise and the statutory duties to comply with the Care Act here. But yes, if your question is, was the department sort of all-knowing as to what was going on across the 153 local authorities in this space? No, we didn't have that information.
Right, so from the point of view of central government, there wasn't any effective monitoring of how the easements were operating and whether local authorities were using the easements or the flexibilities.
So there was effective monitoring of those who were using easements, but we didn't know what was going on for those who were not using easements.
And equally, from the point of view of central government, there wasn't any effective monitoring of whether local authorities were failing to meet care users' needs during the pandemic, for example, by cutting their care packages, was there?
I mean, I have not seen any evidence that that was the case. The evidence that I've seen of the sort of flexibilities that were being used were things like delaying financial assessments, that sort of thing. But I'm not all-knowing, so it's possible. But in terms of the evidence that has come to me.
I'm not sure if you were following the inquiry this morning, but the inquiry heard from Age UK today that local authorities had reduced care packages for people living in their own homes. Were you aware of that?
I mean, what I've heard from, just anecdotally from directors of adult social services is that people asked to have the care packages reduced because they were worried about people, say, who hadn't been vaccinated going into their homes. But look, if Age UK have got evidence of that, then I accept that.
So similarly, if there is evidence, as there is, of daily care provision of someone who, for example, is used to receiving care 3 times a day and that being reduced down to once a day so that, for example, they didn't get dressed for a prolonged period of time because of the inability to meet their eligible needs. Would that be something above and beyond the examples you've given of day services closing or people of their own volition declining services?
Yes.
And again, would that be a matter of concern and a matter of interest to the department, having brought in the easement provisions, to know whether that was happening across the country?
Yes.
And if that was happening, but only a very small number of local authorities had formally invoked the easements in the way that the guidance and the legislation had told them to, might that also bring into question whether the guidance itself was being properly understood or perhaps not complied with because these things were happening and yet there was such a small number of reports?
I think the question it brings into play is the Care Act flexibilities and whether, if it really was the case that someone was having a package of care to take them down from 3 times a day to 1, once a day. I mean, it would be interesting to know what other circumstances there were, because I mean, other things I've heard from directors of adult social services is that there were family members were more around. So, I think you can't judge too much without really understanding all the circumstances of the case. But I do think that this brings up a question about the flexibilities within the Care Act. Is the width of the discretion there? Is it too wide? And I think we need to look at that. And again, I would expect, that will be looked at by the CQC when they're inspecting how local authorities operate their Care Act duties. And 2, I would expect Baroness Casey to look at that as part of her review.
And after you came into post in October 2020, the Think Local Act Personal partnership that had been engaged by the department on an ongoing basis in relation to easements had provided a review which described a very grey line between Care Act easement implementation and other local authority responses to COVID-19. That raised precisely this problem, didn't it, of which was happening and whether care needs were being appropriately met.
Well, it comes back to the point I've just made, which is the degree of flexibility within the Care Act.
And a further submission to the Minister in November 2020 suggested and referred to ADAS that the national guidance was unclear, open to interpretation, and that this was limiting the use of easements by local authorities. Did that trigger any change or review of the guidance while you were in post?
We stopped using easements, and when we consulted about turning them back on again, as I said, for the purposes of Omicron, the universal view was they were not needed.
Right, but they remained in post, though, for 10 months of your...
Yes, but they were not being used.
According to the information you had, is that right?
Yes.
Thank you, Melody.
Thank you very much, Ms Beattie. That completes the questions we have for you, Ms Dyson. You mentioned burden on providers. I am acutely conscious of the burden the inquiry places on material providers and on our witnesses. You may want to take the, I'm sure, glad news back to the department that the burden that the inquiry has placed on the department for which you currently work is coming to an end. We haven't finished with the department yet, but it is coming to an end. But also, I'm sure it was a great burden on you to have to catch up on what had happened in such fast-moving times when you weren't in post. So thank you very much indeed for all that you did to get yourself up to speed and for helping the inquiry to the extent that you have.
Thank you.
Thank you. Very well, I shall return at 10 o'clock tomorrow.
Thank you, my lady.